In this video lecture, we'll review different options for psychotherapy for treating depression and take a look at some research evidence for the efficacy of two types of treatment. There are a wide range of empirically supported therapies to treat depression. Remember that ESTs are treatments that have strong research evidence supporting their use. For depression, we have ESTs from a range of theoretical perspectives. They include behavioral interventions, such as behavioral activation, cognitive interventions, including cognitive therapy, and third-wave cognitive therapies, such as acceptance and commitment therapy, and a form of cognitive therapy called mindfulness-based cognitive therapy. And they also include psychodynamic therapies, including interpersonal psychotherapy and short-term, more traditional psychodynamic therapy. In this list, the treatments that are noted in italics have moderate research support. These include acceptance and commitment therapy and short-term psychodynamic therapy, while those that are not listed in italics have strong research evidence supporting their use. So these include behavioral activation, cognitive therapy, mindfulness-based cognitive therapy, and interpersonal psychotherapy. And when we look at the efficacy of these various kinds of treatment, we can see that they generally have comparable efficacy compared to our antidepressant medication, particularly cognitive behavioral therapy and interpersonal psychotherapy. We see about a 50% response rate. So remember that response is defined as at least a 50% reduction in symptoms. So compared to our antidepressant medication, these empirically supported therapies work just about as well. So we are going to talk in more detail about two of these empirically supported therapies, cognitive behavioral therapy and interpersonal psychotherapy. Interpersonal psychotherapy is a short-term form of psychodynamic therapy, and it is based on the idea that depression tends to occur in an interpersonal context. So often it is precipitated by some kind of interpersonal stressor, and depression is often maintained by interpersonal conflicts and can also cause difficulties in interpersonal relationships. So the goal of interpersonal psychotherapy is to reduce the symptoms of depression by helping people gain insight into patterns in their interpersonal relationships. So like traditional psychodynamic therapy, it's based on the idea that our early childhood experiences shape our patterns in relationships and behaviors throughout our lives by influencing unconscious processes. But in interpersonal psychotherapy, we focus on present moment interpersonal relationships and specifically addressing how those patterns in relationships are contributing to symptoms of depression. So interpersonal psychotherapy is a short-term treatment, often between 12 and 16 weeks, focusing on present patterns in interpersonal relationships. And it will target one of four possible interpersonal problem areas. So the therapist will conduct an interpersonal inventory and assess an individual's important relationships and patterns in those relationships. And they'll then identify one of these interpersonal problem areas that seems to best characterize the individual's interpersonal difficulties. So these problem areas include grief or loss. They might be interpersonal disputes or conflict. It might be related to role transitions, or it might be interpersonal deficits, so inadequate relationships or a lack of effective skills for developing and maintaining relationships. And the therapist will work with the client to improve these interpersonal problem areas, for example, by helping them address communication and helping them identify patterns in their relationships with the goal of modifying those patterns to improve their interpersonal relationships. And the theoretical idea suggests that by improving these interpersonal relationships, that this will then lead to a reduction in depressive symptoms as these patterns in their interpersonal interactions are modified and these interpersonal stressors and conflicts are reduced. So to take a look at the efficacy of interpersonal psychotherapy, I'm going to show you results from a study of 63 depressed adolescents who were treated in a randomized controlled trial. So this was a study where the participants were randomized to either receive 12 weeks of IPT or treatment as usual. So this is abbreviated TAU, so that's a control group that did not receive the psychotherapy. So what you can see in this graph, this is looking at depressive symptoms. This study used the Hamilton Clinical Interview for Depression, or the HAM-D, and they assessed depressive symptoms over the course of treatment. So starting at pre-treatment and continuing across the 12 weeks of treatment. So what you can see is that at the beginning of treatment, this is a randomized controlled trial, we have no significant difference in depressive symptoms between our two groups. As we get into week 4, we see the groups start to diverge, and the participants who are receiving IPT have lower depressive symptoms than our treatment as usual group. This difference is not yet significant. By the time we get to 8 weeks into the treatment, the group receiving IPT has significantly lower symptoms of depression than our control group. And this is also true at the end of treatment at 12 weeks. So here we can see evidence from a randomized controlled trial that interpersonal psychotherapy for depression is more effective in reducing symptoms of depression than treatment as usual. Another empirically supported therapy for depression is cognitive behavioral therapy. So as you might guess from the name, cognitive behavioral therapy combines elements from cognitive therapy, targeting the way that people think about events, and also incorporates elements of behavioral therapy, so changing depressive symptoms by directly targeting behaviors. The C in CBT addresses these cognitive factors. So in cognitive behavioral therapy, we are helping individuals identify their automatic thoughts. We're also educating them about common cognitive distortions and helping them identify patterns of distorted or biased thinking in their own automatic thoughts. Cognitive approach also involves helping individuals evaluate the evidence supporting their thoughts and challenge those thoughts, and helps them generate alternative and more balanced and realistic thoughts. As an example of what you might do in cognitive therapy, you could do this either in written form using something called a thought record, or you could do this verbally. You can help an individual go through a scenario in which they experienced a negative mood by helping them identify their thoughts and consider alternatives. So an example situation might be you find out that 3 of your friends went out to dinner together last night without inviting you. So to identify the automatic thought, you might say, what's the first thought that went through your mind when that happened? A common depressed interpretation or attribution would be, my friends don't like me, they're purposefully excluding me. And the consequence of that thought, you can consider the feelings. So the person might feel sad. You can ask them to identify the intensity. So on a scale of 1 to 10, how sad do you feel? You can also think about the behavior. So what was the consequence? So a common behavioral response for a depressed individual might be that they stop getting in touch with their friends. So they think, my friends don't like me, they don't want to hang out with me, so I am going to stop getting in touch with them. I'm going to stop reaching out, and I'm not going to tell them that I want to see them. So then in cognitive therapy, you can help the individual identify their cognitive distortions. So for example, if you are assuming that they didn't want you to come, what is the evidence in support of that? And are there potential alternative explanations? So for example, did you have other plans and one of the friends already knew about your plans, so they didn't invite you because they knew that you wouldn't be available? Or maybe they went to a restaurant that they knew that you don't like, or maybe it came up casually. Maybe they happened to be in the same area and ran into one another, and it was not planned. So it's not that they purposefully didn't want you to come to dinner, it just happened. So in cognitive therapy, you can help people identify their characteristic patterns of interpretation. So for example, if you are thinking, my friends don't like me and they don't want to see me, that's an example of mind reading. Your friends haven't told you that they don't want to see you. You are reading their minds and assuming they don't want to see you because they didn't invite you to dinner. So as a final component of this, you can generate alternatives. What are some other ways of viewing the situation, and how does that change the consequences? So how does that change The emotional consequences. Are you experiencing other feelings, and has that changed the intensity of the sadness? And does that change the behavioral response? Are you going to continue not to get in touch with your friends, or might you reach out and say, I was really sad to see that I didn't get to see you guys at dinner. Can we make plans for all 4 of us to get together and go out? So the C in CBT helps people identify patterns in their thinking and modify those patterns to be more adaptive and realistic. The B in cognitive therapy, or cognitive behavioral therapy, focuses on directly changing behaviors. One way of doing this is through activity monitoring. So in activity monitoring, you have the individual keep track of their behaviors. There are lots of different ways to do this. So you can have people just keep track of what they are doing with their time throughout the day. A common way of doing activity monitoring is to have people keep track of 2 different kinds of behaviors that we often see reduced in depression. So these include pleasurable activities, so things that people do that they find enjoyable and pleasurable, and mastery activities, so things that people do that give them opportunities to feel successful and like they have accomplished something. So one thing you might do in CBT is have people keep track over the course of a day of how many things they do that are pleasurable and how many experiences they have that they consider mastery experiences. And by having them monitor these activities, you can identify where they have low levels of these, so you can get a sense of how many experiences they're having that are pleasurable or that provide opportunities for mastery. And by monitoring this can also make people more aware of different opportunities to experience more pleasurable activities or to engage in activities that give them an opportunity for mastery. Another behavioral intervention is called behavioral activation. Behavioral activation has also been used as a standalone treatment without the cognitive component. It's also an empirically supported therapy for depression, but it's often combined with the cognitive elements in cognitive behavioral therapy. Behavioral activation directly addresses that behavioral model of depression where we are thinking about decreased opportunities for positive reinforcement by directly leading individuals to engage in more behaviors to increase the opportunities for positive reinforcement. So this may involve things like scheduled activities or giving a client homework of you will engage in this particular activity, and it might involve problem solving. So for example, identifying a specific activity, scheduling it for a particular period of time, and creating some kind of accountability structure to ensure that the individual is following through on engaging with that behavior. So by increasing the behaviors that a person is engaging in, so maybe your behavioral homework is you have to go for a walk at 10 a.m. every day, or your behavioral activation might be this week you will text 3 different friends at some point throughout the week. So by directly changing behavior, the goal is to increase opportunities for positive reinforcement to improve depressed mood. To evaluate the efficacy of cognitive and cognitive behavioral therapies, we're going to look at evidence from different studies evaluating different research questions. So first, we're going to look at a study addressing the question of whether cognitive therapy is an effective treatment for major depressive disorder. So this was a study of 240 adults who had been diagnosed with major depressive disorder and either had moderate or severe symptoms of depression. This was a randomized controlled trial, and the participants were randomized to 3 different groups. One group received antidepressant medication, another group received a placebo, and a third group received cognitive therapy. So all of these groups received 8 weeks of treatment. And at the end of 8 weeks of treatment, the group that had received the placebo was then started on antidepressant medication, and they were followed for another 8 weeks. So in this graph, we can look at depressive symptoms, and we are looking at response to treatment at 8 weeks. So this is the proportion of participants who were classified as treatment responders. Their symptoms had decreased by at least 50%. So 8 weeks after starting the treatment, we can see that about 50% of participants in both the antidepressant medication and cognitive therapy groups had been classified as treatment responders. There was no significant difference in the proportion of responders between the depressant medication and the cognitive therapy group, and both of the groups were more effective than the placebo. So this suggests that cognitive therapy is effective for treating major depressive disorder and is just as effective as our antidepressant medication treatment. And then they followed them up at 16 weeks. So we have no placebo group, because remember, those participants who had been assigned to the placebo group had started receiving antidepressant medication after 8 weeks. And when we look at treatment remission, we can see that comparable proportions of participants in both the antidepressant medication and the cognitive therapy group had achieved remission. So remember that remission is classified when an individual no longer meets diagnostic criteria for the disorder. And again, just under half of participants, both in the antidepressant medication and the cognitive therapy group, had been classified as in remission 16 weeks after the treatment started. So this provides evidence that cognitive therapy is an effective treatment for major depressive disorder and has comparable efficacy to our antidepressant medications. Another question that we could look at is whether cognitive behavioral therapy prevents relapse or recurrence among patients who have been successfully treated for major depressive disorder. So not just do the symptoms improve, but what is the long-term trajectory of symptoms in these individuals. This figure presents results from a study of 40 patients with recurrent major depressive disorder who had been successfully treated for depression with antidepressant medication. So after they had achieved remission, they were randomized into 2 groups. Half of the patients received cognitive behavioral therapy, and half of the patients received clinical management. So they continued to meet with a physician who managed their antidepressant medication. And over the follow-up period, all of the individuals were tapered off of their antidepressant medication. And they were followed over a 2-year period of time to assess whether these individuals who had successfully achieved remission experienced a subsequent depressive episode. So in this figure, we can see that over the 2-year follow-up period, only 25% of the participants who received cognitive behavioral therapy experienced a subsequent depressive episode. This is in contrast to 80% of the participants who only received clinical management, so who did not receive cognitive behavioral therapy. So this suggests that the cognitive behavioral therapy was more effective in preventing the recurrence of a subsequent depressive episode. We have further evidence that cognitive behavioral therapy can help prevent relapse or recurrence from a meta-analysis of 8 different studies that compared the efficacy of cognitive behavioral therapy to antidepressant medication for preventing subsequent episodes of depression. So in these 8 studies, 5 of the 8 studies found that cognitive behavioral therapy was superior to antidepressant medication. So participants who received CBT had a lower risk for relapse or recurrence. 3 of the 8 studies found no difference. So CBT and antidepressant medication were equally effective in 3 of the 8 studies. So overall, the evidence suggests that cognitive behavioral therapy is not only effective for treating symptoms of depression and is equally effective as antidepressant medication, but that when it comes to long-term symptoms of depression, that cognitive behavioral therapy might actually be superior to antidepressant medication. Finally, we can consider whether combined therapy is more effective than either cognitive monotherapy or antidepressant medication monotherapy. So do we get better results by combining cognitive therapy and antidepressant medication than we would get from either treatment on its own? So to answer this question, I'm going to show you results from a mega-analysis. So this was a study where they took results from 6 separate randomized controlled trials where they compared antidepressant medication to cognitive behavioral therapy for major depression. So by combining these 6 studies, they had a total of 695 patients. So that's a really large sample size. So first, we can look at remission rates. This is the proportion of participants in all of these 6 studies taken together who improved and achieved remission over the course of treatment. So we can see that psychotherapy alone compared to combination therapy of psychotherapy with antidepressant medication, in all of these groups, we are seeing an increase in remission rates over time. Most of the treatment groups achieve that 50% remission rate by 16 weeks post-treatment. We see a slightly lower remission rate for psychotherapy alone for patients with more severe depression. And this highlights an important finding. So what this study suggests is that when we compare remission rates for individuals with less severe depression, so mild or moderate depressive symptoms, we do not see a significant difference between cognitive therapy compared to combination cognitive therapy plus antidepressant medication. We see a slightly higher response rate for mild and moderate depression, but that difference is not statistically significant. In contrast, for individuals with severe depressive symptoms, we see a clear advantage for combining cognitive therapy with antidepressant medication. So for individuals with severe depression, they were much more likely to achieve remission if they also received antidepressant medication in combination with the therapy than if they only received the therapy on its own. So taken all together, results of these different studies suggest that cognitive therapy and cognitive behavioral therapy are effective treatments for major depression that result in lower symptoms of depression, that cognitive behavioral therapy may be more effective than antidepressant medication for long-term outcomes and preventing subsequent depressive episodes, and that for individuals with mild and moderate symptoms of depression, cognitive and cognitive behavioral therapy alone has comparable efficacy to combined treatment. However, for individuals with severe depressive symptoms, there appears to be an advantage for adding antidepressant medication to the psychotherapy.